I don't know why anyone doesn't want to attempt my last name, but...
And you can take your mask off if you want.
Okay.
Because I think you're far enough away from everyone.
I won't infect anybody. So I'm Brandon Zabukovic. I am a family physician up in South Bend who I've kind of gone on and gotten board certification in addiction medicine and kind of run a program that is aimed at getting folks with pregnancy, young moms and families into treatment for complications of poverty, addiction, and mental health. So that's kind of my background. As I said earlier this morning, I wish that I could say that I kind of came out of medical school with some sort of enlightened viewpoint on addiction and the like. It's honestly not the case. I think I probably had moments when I was a little bit annoyed by having to take care of patients with addiction that weren't doing well until I had some tools that I could actually use to do a better job. And since that point, like I said, it's become a pretty big part of my practice. So I gave a talk earlier this morning to some of the community folks. So there's a bundle of slides in the beginning that I'm eventually going to skip over. But will be available to you guys when you get the slide deck by email. So. Give him a second here. Disclosure-wise, I have no conflicts of interest that I'm aware of that you guys would need to know about for this discussion. So why don't we work on paper for a minute? We got about 70 minutes, and I want to get through a bit. So I think everybody has the PowerPoint in front of them at this point. So let's go to the kind of agenda page. We'll go over just some very background statistics and some definitions to make sure we're all kind of talking the same language. I know I'm kind of preaching to the choir with regard to is this a problem that we should even be talking about? You guys are on the front line seeing it every day. So I'm not going to belabor that point a whole heck of a lot, okay? So just looking at statistics here. Substance use disorders in pregnancy in general have been on the increase, particularly in younger folks. Looking at opioids and cannabis specifically, those are the two that have been on the greatest rise over the last few years. I have a little bit of dated statistics, but they're not terribly out of whack from what I think we're seeing. 2017 nationally, about 7 out of 1,000 births.
Can somebody tell Matt that he's muted and we can't hear anything he's presenting?
Sorry. IT stuff never comes up, eh? I'm going to keep going since this isn't the most salient part of the talk. Statistically, 2017, about 7 out of 1,000 newborns in the U.S. ended up having symptoms of neonatal opioid withdrawal syndrome. About 30 per 1,000 require an elevated level of care for treatment of neonatal opioid withdrawal syndrome. In the state of Indiana, in 2018, our rate was 9 per 1,000 newborns developing neonatal opioid withdrawal syndrome. So slightly worse than the national average, which I think will probably not be a humongous surprise for anybody in the room. In 2017, particularly salient to your institution because your institution is part of this task force. There are 21 hospitals in the state that submitted 3,000 umbilical cords in the year 2017. Of those 3,000 cords, 14% were opioid positive and 20% were positive for multiple substances. So 1 in 4 or 5 kiddos, 5 or 6 kiddos exposed to some substance in an institution like yours, because you're one of those 21. So all in all, that comes out to about a baby in the U.S. every 15 minutes that's going to have symptoms of neonatal opioid withdrawal syndrome, something like that. So it's a pretty real thing that I'm sure you guys are seeing. Statistically, statistics are always kind of squishy anyway. We can bend statistics one way or another. The last election cycle was a great example of that. But particularly with these kind of statistics, there's lack of standardization for what meets criteria for NAS or NOWS. So it's a little bit hard to compare state to state, institution to institution, but we do our best. Many pregnant and postpartum women are going to be using more than one substance, things plus alcohol or nicotine, particularly. Cannabis is a lot of folks are using cannabis right now as well. We know that other factors that increase the rate of neonatal abstinence syndrome or NOWS include unemployment, poverty, and lack of access to mental health. So if you think about kind of root cause analysis of this problem, like working backwards to unemployment, poverty, and mental health, it makes a lot of sense that if those things are difficult in your community, that addiction is going to be a little bit harder to handle. I think your community, like every other community in the world, probably has a relative dearth of mental health providers. You probably don't have counselors and psychiatrists sitting around twiddling their thumbs waiting for patients. They're all probably at capacity or greater. So, and then just, I'll throw in the obligatory COVID is bad slide. In the context of pandemic and everything else that's kind of befallen most of our communities, things have gotten worse from a substance use standpoint during COVID. Social isolation, increased burden of childcare on parents who would normally be at work with kids at school, and decreased access to healthcare because of the things that we've done to try to protect ourselves and other patients, all contribute to how COVID has had a negative impact on substance use disorders in general. Okay, so I'm going to skip through some of the background slides that y'all don't need to see. One thing just that's interesting, if we think about types of substance use, illicit substances that are legal, alcohol, nicotine, prescription drugs that can be misused, illicit substances, and medication-assisted treatment. Marijuana, depending on your locality, can fit in basically any number of those categories. It could be legal, it could be prescription, it could be illegal, and there are certainly some folks out there in some communities that are using it purportedly for substance use disorder, though I don't think it's a really great idea. All right, so let's as a group here on paper, let's jump forward to page 7 on the bottom right. There we go. Because you all know all this. Okay, so what can the folks here do? So we have obstetricians, pediatricians, nurses, and I think folks for 4 County calling in. The earlier we can identify women at risk or of substance use or that actively using, the more time we have and the greater tools we have to actually affect change and to help them. Okay, so the early detection part falls a lot on prenatal care providers, actually. You guys are in a particularly unique place to do some of this, okay? If you're looking at, so what have a lot of communities have traditionally done is say, okay, I'm gonna screen or intervene on people that I'm identifying as being at risk. Kind of it walks like a duck and quacks like a duck. It's probably a duck kind of model of doing this. So looking at risk factors, these are a long list of risk factors from a historical standpoint for the providers that are interviewing patients to say, okay, this person has history of a partner with substance use or another mental health condition. They have children that are not living with them. If we learn those things, then yeah, that they probably, this person statistically speaking has a higher than average risk of a substance use disorder, okay? Particularly for you guys, an unexplainable obstetric history of preterm labor abruption, IUGR, IUFD. If you're taking their history and you're like, oh man, that doesn't make a lot of sense based on everything else that I know about this person medically, perhaps raise your radar for, was there a substance use disorder present during that pregnancy that led to that outcome that we can't otherwise explain. Okay. Medical risk factors, when you're doing your exam, do they have skin and soft tissue infections? Were they admitted for, bacteremia that's unexplained? Are there physical signs of current substance use, like track marks? Do they have nasal mucosal irritation or ulceration? Or are they actively having signs of intoxication or withdrawal? Certainly those are some things that you could see to say, hey, this person may have a substance use disorder. But in general, this is a Where's Waldo from my kids' childhood era. It may not be a thing anymore, I don't know. But what does a substance use disorder person look like? Well, they kind of look like everyone in this room and everybody else you've ever met. It spans across all demographics, really, right? So I think that walks like a duck, quacks like a duck. It's probably a duck model is probably an insufficient way for us to identify women at risk. In a large system that just screened everybody for a study, they basically found that the system, by doing just picky and choosy testing, missed a third of babies or a third of families that would eventually have DCS involvement for substance use disorder. So much like we think we probably do a good job of identifying people when they're in front of us, we probably don't do a super good job of finding everybody with a substance use disorder based on just asking questions and making assumptions. So there is a big push for more routine universal screening for substance use disorders in the context of pregnancy. I'm all for it. Certainly by standardized questionnaires or interview questions about, do you have substance use disorder, which I'll talk about in a second. Use of universal drug testing is a little bit debatable. I'm personally for using it. We screen for syphilis twice in pregnancies, and syphilis rates are certainly way less than substance use disorder rates. So I don't think there's a real valid argument for the costs of, a $5 urine drug screen with regard to this. I think the pros way exceed that. That same 21 hospital task force in Indiana, they recommend that we do opt-out testing, similar to how HIV testing has historically been. You can opt out of drug testing in prenatal care, but then your baby, we're going to kind of keep around for 48 hours, and we're going to do a drug test on your baby, which makes some sense. We lose the opportunity then to actually intervene during the course of pregnancy to try to help them so that they don't have substance use disorder that persists all the way to delivery, but at least we're identifying babies at risk in that context. And then just use of the PDMP, the inspect. I think probably most EHRs, I don't know if yours does, but most EHRs have just a click that pops the PDMP report up, so you don't have to log into a second website. Do y'all have that, hopefully? So.
We were told at our meeting on Friday that Cerner does have that, but nobody knows how to use it.
Knows how to use it, okay. I do believe Cerner does. If it's not turned on yet, the state will do it for free. All you have to do is call the medical administrative licensing, the BLA, the PLA, Professional Licensing Agency, and they'll help get that set up if it's not already. So it's really nice to just have one click. It's one of those things, logging into another website, remembering another set of passwords is a silly obstacle, but still an obstacle to us doing PDMPs. So I think using those resources prenatally is a great way to identify some of these folks. Some of the challenges of screening, some of the questionnaires don't function well across all cultures and languages. There's obviously fear of stigmatization and risk of legal action that moms are concerned about, including involvement of Child Protective Services. When we're doing that screening, I recommend that most offices have kind of a couple people that have rehearsed the discussion a little bit, because if you're coming in for prenatal care and I say, hey man, we're going to do a drug test because we want to find out if you're using so that we can take baby away, right? Like I'm going to hyperbolize a little bit here, but clearly that's very different than if we say, hey, we're concerned about your overall health and the health of your pregnancy, so we're trying to identify people at risk of a substance use disorder so that we can help them along the way so their baby is as healthy as possible and they get to take them home, right? So the same discussion can be slanted in very different ways with very different responses from patients and a very different feel for that kind of therapeutic relationship. So it's nice to have those things kind of scripted out a little bit and maybe have a few people that are good at it to have that talk with patients. Decisions to report substance use disorder to Child Protective Services, they should be based on your understanding of risk to children in the home. Just because somebody tests positive for something does not mean that we have to refer to DCS if their children are well taken care of and they're coming to appointments. There's some opportunity there to take care of them without an immediate DCS referral. I'm going to talk about HEA 1007. It's Indiana legislation. I have another slide for that. Other obstacles for screening, if we ask a question and we get an answer, we should have some response to that. So there is some reluctance in some OB offices I've talked to ask because they feel like they are powerless to deal with the response. So making sure that we have a nice network and we're aware of local resources so that we can make appropriate referrals after we find out someone has substance use. And then denial and guilt of the person involved. Sometimes that shades the way that they respond to your questions. A couple screening options. The 4Ps Plus is a nice one that I'll show you in a second. It is a copyrighted one that you have to buy the rights for if you're going to use that in the office. The NIDA Quick Screen isn't pregnancy specific. But it does include substances that are both illicit and prescription, and it is free to use. So if you're really trying to pinch pennies, I think the NIDA Quick Screen is a good option. If it's something that could potentially be like baked into your EHR or something like that, I think maybe the 4Ps is a good option, but there's a couple there for you. This is the 4Ps. So you can see that when asking these questions, you're kind of asking about a big shell around the person first. Parents have any trouble with substance use? And then getting a little bit closer, partners have any problems with substance use disorder? A little bit closer, in your history, in your past, have you ever used substances? And then asking about present use. So we're gradually, hopefully, chipping away at that kind of guard that people have so that we can get a good positive answer, or a good accurate answer, okay? And then any yes would trigger more discussion. And then this is that NIDA Quick Screen. So the non-pregnant version is to say in the past year, have you done those things? And it can kind of quantify it out a little bit. For pregnant women, we generally recommend that we ask in the context of since you became aware of your pregnancy. If they used alcohol prior to pregnancy and they stopped when they discovered pregnancy, which I think probably happens a fair amount, great, you did the right thing. We definitely don't need to make a report about that or make a special note in the chart per se, unless maybe they didn't discover their pregnancy until 30 weeks, and that may raise your radar about something else. So HEA 1007, so that's Indiana state legislation regarding the screening of pregnant women for substance use disorder. So this legislation says that prenatal care providers are required to use some sort of screening tool, preferably one of those validated screening tools, to inquire during prenatal care about substance use. And then if it's identified, they're required to make a referral. If they can either provide treatment themselves. There are some obstetricians that, as example, have become buprenorphine prescribers for this reason. They're required to do it themselves or refer out based on this legislation. Now, with that said, so you think that makes us think, well, golly, patients would be super reluctant to tell us about anything because then we have to make a report, right? So the converse is true. That's the perception. The converse is true. According to this, we cannot release the results of drug testing or that verbal screen on moms to DCS without parental consent, unless there are other children in the home that may be at risk based on what you're surmising from that discussion. So if they're like, yeah, I use heroin every day and I've overdosed twice and I go out at night while my kids are sleeping, okay, kids are at risk, call DCS, easy, right? If it's, I use heroin, I don't have children at home, we cannot at that time inform DCS or share those results of that screen with DCS without parental consent or a court order. Now, if the baby comes out and they themselves test positive in the nursery, they exhibit signs or symptoms of withdrawal, or there's parental behavioral issues that make us suspicious of their ability to take care of a child in a nursery setting or a postpartum setting, then we can make a report without parental consent. Does that make sense? So this is a nice part to kind of file away when you're having those discussions to say, okay, listen, again, we want to find out so we can help. Not only do I not have to report this to DCS if everything else is squared away, I can't report it to DCS. As long as you're managing your business, your kids are not at risk, you're getting into treatment. Does that make sense? So there are some states, like Tennessee is a good example. In Tennessee, it is mandatory to report prenatal, maternal drug use, and it is a criminal offense in the state of Tennessee that they would get reported and arrested. Okay, so they're way on the other side of the spectrum of how their laws work. Clearly a whole other dynamic happening in Tennessee than what this law is kind of set up for us in Indiana, so. Okay. So from the hospital side of things, okay, y'all in the room here, we are asking you all to help identify moms and babies at risk, to help monitor and manage babies who are at risk or showing signs of withdrawal. We're asking nursing staff predominantly to help provide supportive care for newborns at risk, and thinking through drug testing of babies and moms. I'm also going to throw in some stuff for the obstetricians on, situations that may hit triage and stuff like that, okay? So again, goals of treatment, we're trying to identify so we can prevent complications. We're trying to get them accessed into the system and facilitate prenatal care. When people are seeing me for addiction treatment and pregnancy, they're more likely to tune in and go to prenatal care appointments on a regular basis. I'm going to ask them every time they come into an appointment with me, how are things going with their prenatal care? So when they're engaged in treatment, they're going to see you a whole heck of a lot more too, which is important. Also trying to mitigate the other risks associated with drug use and drug culture and trauma and exposure to other infections and the like. And then to try to avoid the risks of ongoing use, that cycle of intoxication, withdrawal, and exposure to adulterants and other crap that's in the drug supply is helpful as well. Okay. So, in a perfect world, let's talk about patients that are identified, moms that are identified in a hospital setting. So they come to OB triage and they can be discharged from an obstetric standpoint and they're having mild withdrawal symptoms. Okay, in a perfect world, we would be able to plug them into an outpatient substance use provider to be seen within a day or two, a business day or two. Okay, that would be a very reasonable approach to those folks. Okay. For people that are admitted to the hospital for an obstetric indication and are showing admission at the hospital, in a perfect world, you'd be able to get an inpatient consultation with somebody that can help manage that for you, an addiction medicine doctor, a primary care doctor with experience, a psychiatrist. I don't know what your resources are at this institution, honestly, with that. And then postpartum management, after a cesarean section, most folks are getting some opioids, so that can mitigate some of opioid withdrawal after a cesarean section. And then depending on kind of patient readiness to access treatment, a referral can be made from the hospital setting to treatment. Okay. So I'm going to talk a little bit about opiate use disorder in a prenatal pregnant lady perspective. We want to avoid acute withdrawal from opioids in pregnancy due to risk of miscarriage and preterm labor. So this is not a population of folks that you want to say, okay, I'm going to send you to an abstinence-only social detox where you're just going to kind of bite a belt and suck it up and get through withdrawal. That carries with it a lot of risks. So we want to avoid those kind of situations. There are some medically assisted withdrawal, like short medical assisted detoxes, 3 to 5 days. Those are probably safe in an obstetric standpoint, but the risks of relapse in that context is pretty great. So like the American Society of Addiction Medicine, they don't even recognize the notion of medically assisted withdrawal programs. So we need to, particularly in pregnancy, get them started on some semblance of medication, and then we just follow them through the pregnancy. Now I'll talk about weaning after a pregnancy, but we kind of want to get a dose that works, set it and forget it, get them through the pregnancy, and then deal with the aftermath after that. Okay. So we talked a little bit about engagement in treatment. Women, moms have a particularly high motivation to do the right thing during pregnancy. So, 3/4 of moms that get into treatment maintain that through the end of pregnancy, which is a higher number than we see in non-pregnant population by a fairly wide margin. Most of these women want to get better. Okay. So long list of benefits of medicated assisted treatment and drug treatment in pregnancy. I'm not going to read that to you because you guys are good readers. So I want to talk a little bit about, for opiate withdrawal, buprenorphine versus methadone. Now it sounds like there is not an outpatient methadone clinic that's terribly close to you. I think probably from a methadone OTP standpoint, the closest one is probably South Bend or Fort Wayne or Indianapolis. Geographically, you fit in the middle of all that. I've learned today since I've been down here. So pros of buprenorphine. Buprenorphine is a partial opioid agonist and a partial opioid antagonist. So if you think of like an opioid receptor as like a cup and an opioid fills that cup, buprenorphine partially fills that cup, but it sticks there. So other opioids can't fit in there because buprenorphine is partially in that receptor. But it does, because it partially fills that receptor, it can treat cravings and withdrawal. With that said, it can precipitate withdrawal if we give it too early. It's going to go into that receptor, kick out the opioid that's there, and stick there. So we can cause withdrawal with buprenorphine. But in general, if we use it correctly, it should treat withdrawal cravings. It will block the euphoric effects of opioids if they use them. It has a long half-life, so there's not a terrible risk of going through daily withdrawal. Okay, so that's the pros. That's how buprenorphine works. Whereas methadone is an opioid, it fits into that receptor just like heroin, oxycodone does. It just has a long half-life and a high affinity, so it stays there longer. They don't experience daily withdrawal generally, although pregnancy can change metabolism a little bit. Keeps tolerance high, so overdose risk is mitigated in people taking methadone. Okay. So some other pros of buprenorphine over methadone that I think are important. There's a low risk of overdose on buprenorphine because it has that mixed receptor, the way it kind of works at the receptor. It's really hard to take too much buprenorphine because you fill the receptors and then it just blocks itself. It just gets in its own way. It'd be like all of us trying to fit through a door at the same time. Like it's just not going to work out, right? So for that reason, buprenorphine is a nice medication. Has fewer drug side effects. Because it can be prescribed in a normal doctor's office, there's some privacy conferred by that. You don't have to go to a methadone clinic where your pastor might see you in the parking lot going to get your daily dose. You don't have to go every day to get a dose. So some of those folks that have sketchy transportation, it can be mitigated by less frequent appointments in a doctor's office. In the context of pregnancy, for methadone in pregnancy, the half-life normally is 22 to 24 hours. In pregnant folks, it drops down to 8 hours. So it's very common in pregnancy to require more methadone to cover that metabolism. It also is not uncommon to start to have to split dose the methadone so that you're taking it more than once a day, which requires the methadone clinic to give you take-homes, which may not be appropriate for where you are in your journey of treatment. You may not be a good candidate for take-homes. It's possible that pregnancy increases the renal clearance of buprenorphine, but it's not enough that we always have to increase the dose. In fact, very rarely do we have to bump buprenorphine dosing in pregnant women to cover the pregnancy, whereas methadone, most places, as soon as they find out you're pregnant, they will preemptively increase your dose of methadone as soon as they find out, which is not great if you're trying to not have a person on high methadone for the rest of their lives. Generally speaking, buprenorphine is covered by insurances, especially in the context of pregnancy. There's not really cardiovascular risk, like methadone can prolong the QT interval. There's lower risk of preterm birth. Buprenorphine babies will have a higher birth weight and a larger head circumference than methadone babies will. And there's a reduced risk of neonatal opioid withdrawal syndrome in babies born to moms on buprenorphine compared to methadone, with a length of stay difference of about 7 days, which is a pretty meaningful length of stay difference. A lot of healthcare dollars saved. The pros of methadone over buprenorphine. Methadone's been around for a long time. There's a ton of data. It's kind of like the Aldomet effect, why Aldomet was the preferred antihypertensive in pregnancy for so long. It's just that it'd been around forever, so we knew the risks and benefits of Aldomet in the context of pregnancy. More patients drop out of buprenorphine programs than they do methadone programs for multiple factors. I think because of the ceiling effect, buprenorphine can't always cover the needs of a person with opiate use disorder, and then those folks need to go to methadone because there's no ceiling, and there's also that daily supervision and structure of a methadone clinic that some people need that extra layer of accountability, and the outpatient buprenorphine can't quite get them there.
How do you compare? I mean, is it significantly larger? I mean,
dropout rate? It's not, less than 10% difference. Buprenorphine can be diverted, can be sold, stolen, taken incorrectly. Some office-based programs aren't particularly stringent with regard to counseling and stuff like that, whereas methadone OTPs, federally regulated fairly strongly. Most OTPs have a system that's kind of regulated. As I talked about, that ceiling effect. And then at a methadone clinic, it's an all-inclusive, everything happens under one roof, whereas in an outpatient setting like ours, we have counseling, we have a peer recovery coach in my office, but sometimes we have to send folks elsewhere to other places, which with transportation complications and the like can be difficult. Okay, so now we're going to talk about fetal biophysical parameters, which will be important for you guys. So methadone first. Babies, when you're monitoring a pregnant woman on methadone, you're more likely to have a non-reactive NST. There's a higher frequency of non-reactive NSTs. You will increase your time to reactivity of your NST. It increases the time to completion of your biophysical profile. It'll take longer for your ultrasonographer to finish that for you. And that's largely due to decreased baseline fetal heart rate, decreased number of decreased fetal heart rate variability, decreased accels, decreased breathing movements, and decreased fetal movements, okay? So methadone does all that to the baby in utero. So when you guys are monitoring a baby either in your office or at the hospital, keep that in mind. It doesn't necessarily mean it's a bad baby in there. It just means that methadone has effects that you need to be aware of when you're doing external fetal monitoring. Buprenorphine and its effects. It can reduce baseline fetal heart rate variability and accels, but it's less pronounced than methadone is. In a head-to-head study of buprenorphine versus methadone, buprenorphine babies had greater variability, more accels. There was better coupling of fetal movement and heart rate in the third trimester. There was more frequent fetal movement. They're more likely to have a reactive NST, and biophysical scores were higher. Doesn't necessarily mean the baby's better per se than the methadone baby. It's just the way your tracing is going to be different, and you'll have to be aware of that. So how do you choose the two things? Like, availability is probably the most important thing, particularly in a setting like this where you'd be asking patients to make a big trip to go to a methadone clinic. Buprenorphine is likely going to be your best option for opiate use disorder in the context of pregnancy. Patients will have some preference. You'll have some folks that just because of stigma largely with regard to methadone, they don't want any part of methadone, but they're more open to buprenorphine, and that's, you don't want a person to try to have to take a medicine every day that they're afraid of. Cost can be a concern. Privacy we talked about, and then that accessibility of support. Now with that said, if a person comes into you stable on methadone, there's really not a valid reason to switch them to buprenorphine just for shits and giggles, and vice versa. If they're doing well on buprenorphine, we don't have to change them to methadone for any reason. Does that make sense? And in fact, it's difficult to get a person from methadone to buprenorphine because of risks of withdrawal in that switch. So if everything's going well, even though we might have some personal thoughts about which one is superior, we shouldn't force a change in that context. From a regulatory piece for buprenorphine, for the prescribers in the room, it used to be that in order to be a buprenorphine prescriber, you had to do 8 hours of online training if you were a physician, or 24 hours if you were a PA, NP, or a midwife, to do any buprenorphine prescribing. Once you were done with the training, then you would apply the DEA for a secondary DEA number, wait for that to come, and then you could start prescribing, and it was a requirement that you had to have the capacity to make a referral for psychosocial support or counseling. You did not have to refer everybody for that, but you had to be able to refer everybody for that. Okay. Legislation recently changed so that any physician with a valid DEA can write buprenorphine for substance use for up to 30 patients without completing training, without getting the DEA waiver, and completely exempt from even the requirement to have the capacity to refer for counseling. I think the rationale for the law makes sense. Like, let's do everything we can to decrease obstacles to get more prescribers out there and get more access. I honestly think it's a little bit scary that there'll be folks prescribing without much experience and without the capacity to refer people for treatment. So I suspect there'll be some minor adjustments to that. Now, let's say it's something that you love and you want to take care of more than 30 people, or you need it in your community. If you want to go above 30, then you have to do all those other steps we talked about. Okay, you can go up to 275. I have about 60, and I couldn't honestly imagine 275, because I think if you're doing it right, 275 would be hard to handle the needs of that many people. Okay. So some just miscellaneous parts about medication-assisted treatment. The duration of treatment, it came up this morning. How long should a person be on medicated-assisted treatment? It's debatable. Like I said, there are some folks that think that we should do 3-day detoxes and then stop. Statistics on that population, not great. There's some experts that think that you should go on it, stay on it forever, like your daily multivitamin. I've heard some experts say that you should be on MAT for twice as long as you use the substance, which for some people is a lifetime. They've been on it since they were 12. If you look at like functional brain imaging at about 18 to 24 months, some of the dead parts of the brain, the dopamine access stuff, start to light up again. So kind of in my experience, and with that in mind, that feels like the right time to start to have some conversations about weaning the medication. In 18 months, they're likely going to have cleaned up some of their legal stuff. They're likely to have DCS kind of squared away, hopefully housing stable, and all that stuff that's around them is hopefully better, and their brain's healing a little bit. Now let's think about kind of peeling away medication a little bit, okay? But with that said, there's no hard and fast rule. And if a person's doing well on buprenorphine or methadone without side effects, we shouldn't freak out if they stay on it forever, just like we probably don't freak out if someone takes lisinopril for hypertension forever either. Okay, it's fine. Remembering that it's medication-assisted treatment. It is not MT. The medication isn't the treatment. The medication stabilizes people so that they can engage in other things and not feel like shit when they're going to the doctor's office and counseling, and that they can go to work and stuff like that. But the psychosocial part is the heavy lift of the treatment. Medication is there as a tool to help them. Okay, so I try to get all of my patients plugged into something, one-to-one counseling, IOP, AA meetings, something outside of the medication. In theory, for y'all here at Salient for You, in theory, there's a potential interaction between buprenorphine and methadone and magnesium in the context of preeclampsia and eclampsia. That has not been borne out in studies in any way. So y'all are monitoring patients at bedside with increased frequency on mag anyway. So just file that away in the back of your head. And then the severity of neonatal opioid withdrawal syndrome in the baby doesn't correlate to the maternal dose at all. So you'll have babies whose moms were on 120 milligrams of methadone or 24 milligrams of buprenorphine, and the baby will have minimal symptoms sometimes. And you'll have moms that were on 50 milligrams of methadone and 8 milligrams of buprenorphine who have babies with significant opioid withdrawal syndrome. And there's the reality, there's a lot of factors that go into why babies withdraw, that it's not just the medicine. So I've done it too. I've said, oh man, this mom was on 150 milligrams of methadone. This baby's gonna struggle. It's not, you try to erase that from your thought process, because it changes the way you assess babies too if you have that bias. Also, so now, any questions so far? Sorry, I'm throwing a lot at you guys. So I'm going to take a step back and just think through the spectrum of pregnancy care, from prenatal to intrapartum, postpartum, and the like. So from a prenatal care standpoint, in addition to what we already spoke about, some of the other things that are important. So women who are using opioids, they are at increased risk of irregular menses, and they're certainly at increased risk of not really noticing when they're on their menses. So dating can be sketchy sometimes. So it's encouraged that in the context of prenatal care, if you have someone with this history, to get an early dating ultrasound so you can just kind of firm that up in the beginning. It also sets some baseline statistics when you're thinking about growth when you do subsequent ultrasounds later in the pregnancy. From an external fetal monitoring standpoint, NSTs and biophysicals, those should be guided and ordered for obstetric reasons only. There's not really a reason to do more NSTs or biophysicals because a person is on MAT or in treatment for substance use. So use everything else to make that decision. Now babies exposed to intrauterine drugs, they may have IUGR. There may be obstetrical reasons to do increased monitoring, but not just the substance itself. Okay. Intrapartum care. So moms coming in, they're in labor or they're coming in for their cesarean section. Things to do here at the hospital. So we should have them continue their normal dosage of buprenorphine or methadone up through labor or until their scheduled cesarean section. Some physicians will divide their total 24-hour dose into 3 and give Q8. Some folks will just say, yeah, just take your dose like you did at home. Either one of those is reasonable to do, okay? There are legal provisions that allow hospital-based prescribers to prescribe these without any of the outpatient legal restrictions on prescribing. If a person is coming to OB triage and they're like, I'm from South Bend, I go to the Victory Clinic and I'm on 100 milligrams a day and I was traveling from Indy and I went into labor and they're here, they're on your doorstep. These things never happen during normal business hours. They're always, Friday night at 2 a.m. or something like that. And if you cannot confirm that their dose, it is reasonable to admit them, do an evaluation of withdrawal, and if they are having clinical signs of opiate withdrawal, to give them incremental dosing starting at 10 to 20 milligrams up until 50% of their reported daily dose, as long as they're not developing sedation. So if they say, I'm on 100 milligrams, you can't confirm it, admit them. When they start to show signs of withdrawal, give them 10 or 20 milligrams, and you can repeat that up to 50 milligrams. Hopefully by then, you'll be able to contact their prescribing institution and confirm their dosing. Methadone is not reported to the PDMP, which is ridiculous, but that's another story. Buprenorphine, that should be visible on inspect. You should be able to see how much, it doesn't give you their daily dose, but you should be able to surmise that they're getting 45 every 30 days. You should be able to kind of deduct a little bit what their normal daily dose is. If you're unable to confirm that for whatever reason, you can do a 2 milligram test dose and then redose up to their reported daily dose, usually divided into a couple divided doses if they're not getting sedated, okay? Again, hopefully we're buying enough time here so that then you can be in contact with their normal prescriber, but you won't have a person languishing in OB triage or in labor in discomfort, and you will not take on the risk of overdosing a person by giving them more methadone than they actually are supposed to be taking, okay? And then remembering on an intrapartum standpoint, the IV placement can be difficult even in someone who has long-term sobriety because of the damage done. So, at our institution, there's a fair amount of women that elect to not have an IV placed when they're in labor. It's not probably better, it is better to get a functioning IV that you don't use than to be trying to place an IV when the shit's hitting the fan. So just get a good functioning IV and hope that you don't need it. Labor analgesia, epidural or spinal is a good option. There will be no real interference from MAT medications for that kind of anesthesia. Remembering that their daily dose, their normal baseline daily dose of methadone or buprenorphine, that's what they need to be normal. It will not confer significant analgesia for them for labor or postoperative pain. So we can't expect that if you're on 100 milligrams 3 weeks ago when you're at work unsedated without pain, that same dose would confer pain management postoperatively, right? I've been there to say, well, that person's on methadone. They don't need any postoperative pain medicine, but they certainly do in order to cover what we've done to them in the hospital. There's no evidence that giving them a short-term opioid increases their relapse risk. They are on medicine and engaged in treatment. I've had patients say, like, if the nurses think that oxycodone does anything for me when I've been using heroin all these years, they're crazy. It'd be like if I got my excitement from, alcohol drag racers, and then someone said, well, go here, drive this, Honda Civic R. It's a sports car, but it ain't gonna make me excited, right? So don't let that freak you out either. We shouldn't be in the habit of just giving additional doses of their baseline medication for pain management. That's not likely going to turn out well. And remembering that they're going to require more doses either due to that partial receptor blocking of buprenorphine or to tolerance and receptor upregulation in the context of methadone. You can use pure opioids in labor. Morphine, fentanyl, those are fine to use with both methadone and buprenorphine. If you use the mixed agonist-antagonists like Stadol or Nubane, you will precipitate withdrawal, and that is difficult to fix sometimes. So try to avoid those things if they're used commonly in your institution in this population of people. Postpartum. So now post-delivery, post-vag, post-cesarean section, we should continue them on their normal daily dose of their medication. Some methadone OTPs will recommend an immediate 20 to 40% drop in methadone dosing because they were automatically updosed when they became pregnant. They'll drop them as soon as they deliver. Ours doesn't immediately do that. They drop them in the outpatient setting. Hopefully there will be some pre-delivery coordination of care from the methadone provider and the prenatal provider about how they want that to be managed. If you don't have that communication, then just keep their normal daily dose going. And then from a postpartum or a post-operative pain management perspective, maximize use of non-opioids, so scheduled acetaminophen and ibuprofen, which we should be doing all the time anyway, I think. And then after a cesarean section or a traumatic vaginal birth, after cesarean section, get them in a binder quickly. That helps a lot. Mobilizing the patient early helps a lot. And then using a pure opioid like oxycodone for breakthrough pain. And essentially remembering the increased need, there will be significant interpatient variability, just like there's significant interpatient variability of pain response in non-opioid users. There will be the same with this population of people. I was going to say something else and I forgot, but I'll come back to it. Shoot, I'm sorry. Oh, yeah, so now you have to use clinical judgment. So if in your clinical judgment, a person with no opioid or substance use history had something happen at the hospital cesarean section, 4th degree with a complicated repair, if a normal patient would require an opioid for whatever befell them at the hospital, then we should do the same thing for a person with a substance use history. We should not deny care to an opioid user who had a cesarean section or a traumatic vaginal birth. The doses will be a little bit different. It's gonna be okay. You're not taking on more prescribing risk. We're not putting the patient at risk. Communicate with the outpatient prescriber so that we know what's happening on our patients coming out, so we don't run an inspect report and see oxycodone and not have a good reason why they had that. And then just remember, again, because nothing happens during normal business hours that we need to sometimes, most insurance companies will require a prior authorization for an opioid prescription for somebody taking buprenorphine. So it's helpful in patients that I'm involved in the prenatal care. We get the prior auth in advance to say, hey, this lady is gonna deliver, they're having a planned cesarean section on Friday. We get the PA in place so that they can not have a problem at the pharmacy on a Saturday when you don't really wanna be messing around with a PA as a prescriber, okay? And I usually offer to prescribe all pain management so you don't have to worry about it. Some of the obstetricians in our community take me up on that and some do their own thing, okay? Okay, and then, so now we've prenatals, we've labored, we've delivered, and now we're at postpartum appointments. We want to have a nice short interval between hospital discharge and an appointment with their addiction medicine provider or their mental health care person. We don't want that to be a see in 3 months thing. A lot's happening that we want to keep close eye on them for. And then y'all are doing this, I'm sure, preaching to the choir, but let's get some contraception on board here as soon as possible, LARC if we can, okay? If it's not contraindicated and the patient's open to it. All right, that's the obstetrical part. Any questions on any of that or discussion or anything? Okay, so now let's talk about babies a little bit, okay? So identifying babies at risk of withdrawal, somewhat historical based on your knowledge of the history of the mom or the family unit. Some of it will be based on drug testing of the baby upon delivery, okay? So from a drug testing perspective, most institutions use some combination of urine, meconium, or cord testing. All have some pluses and minuses. Urine's pretty sensitive, but it only shows very recent use. It doesn't give you much information about what happened before. Meconium is difficult to collect properly, and there's a delay from collection to results. Cord testing's pretty easy to collect. Just make sure that your obstetric provider gets you a piece of cord. Timing can be difficult depending on what lab you use. You may not get results until the baby's been discharged. And then importantly, it can't quantify how much drug was used during pregnancy, and it can't time it. So if a mom used heroin at 21 weeks and then had 20 weeks or 19 weeks of abstinence, they'll have a positive cord. And if they used up until the day before delivery, they're going to have a positive cord, and you won't be able to tell the difference between those two people on the cord results alone. So remember that when you're interpreting those results. You can still, even without those results, use your clinical judgment based on history or what you're seeing with the mom to kind of say, hey, this is a baby at risk we need to keep a closer eye on. Neonatal opioid withdrawal can be potentiated by other substances, including nicotine, SSRIs, gabapentinoids, and benzos. Some things, particularly the SSRIs and nicotine, your patients are going to often be exposed to. NOWS is characterized by a disturbance in one of these 4 states: state control and attention, motor and tone control, sensory integration, autonomic functioning. Those are all the signs or symptoms of withdrawal that y'all know. The presentation of withdrawal is variable, and it will depend on the specific drug that they were using and its half-life, the amount and timing of last dose prior to delivery, maternal factors including nutrition and the metabolism. There are some genetic polymorphisms that change the metabolism of opioids that are listed there. Gestational age. Interestingly, premature babies are less likely to experience significant neonatal opioid withdrawal syndrome than are term babies because they are immature neurodevelopmentally, so that they can't show signs or symptoms of withdrawal as much as a full-term baby. Physical environment plays a major part too. Okay, so yeah, short half-life, drugs usually symptoms within 24 hours, long half-life may take 3 to 5 days. To manage the baby, we recommend maximizing the environment around them, rooming in, which it looks like you guys do here pretty consistently, engaging the mom or other caregiver early, and then using a multidisciplinary team that includes a physician, nurse practitioner, lactation, social work, nursing. All those folks who are seeing things from a different standpoint are important to involve in the care of these babies early. This will be in your handout. I'm going to skip because I think we have about 10 minutes left. So from a non-pharmacologic care, we want to begin things right away and continue them through the hospitalization, regardless of the need for medications for baby. Just get good skin care at the first sign of skin breakdown. Get skin care going, and breastfeed if possible. And there are no other contraindications to breastfeeding. This is kind of an instruction sheet that I give to moms prenatally about or at the hospital, these are the things that I want you to be doing to make your room as homey and and limited withdrawal cues as possible while you're at the hospital. You go into the room, sometimes the TV's on, the cell phones are on, the parents are arguing, the lights are on. It's just like I go through withdrawal syndrome when I go in those rooms. So try to mitigate those things as much as possible. Breastfeeding is safe in women who are engaged in treatment and counseling and got prenatal care and have been abstinent prior to delivery for at least 30 to 90 days. Buprenorphine and methadone are compatible with breastfeeding, and they don't have another medical reason that they can't breastfeed, like HIV or Hep C with nipple breakdown or something like that. Okay. I'm going to skip this too. Hospitalization standpoint, buprenorphine babies and methadone babies, I keep them at least 3 to 5 days at the hospital. I just kind of say, hey, at 72 hours, we're going to assess what's going on and make some decisions. Don't plan on going home before then. We have a lot of 24-hour discharges at our institution right now. I don't know if you guys do down here, but that seems to be a pretty popular thing in moms in South Bend, is to go home at 24. Doesn't sound like that's happening down here.
How do you
But
manage the daily room in question?
close outpatient follow, hopefully.
Sure,
But,
like you said,
yeah.
that place we talked about.
Yeah, we have a TCB in our office and we get them in quickly, but yeah. So plan on a longer stay. When I'm involved in prenatal care, I always tell the parents, plan on a longer stay, because they're going to be getting these social cues, and maybe an obstetrician or prenatal provider that's not cued into this, that'll say, oh yeah, you'll go home at 48 hours, and then they have the expectation of that when I'm going to keep them an extra day at least. Okay.
Do you keep them longer if they are on short-acting opioids?
By 3 days for those folks, you'll know.
Okay, good.
Yeah. Yeah. So some rating scales. Are you guys like a Finnegan hospital? Do you eat sleep and console? Do you use something else? Blended?
Finnegan.
You Finnegan?
We're transitioning
Yeah.
to
You transition to eat sleep and console? We did that. I think it's a great thing to do. So you guys have that background. Finnegans are arbitrary, right? Like what makes an 8 not needing meds and a 9 needing meds? And year 8 is my 9. Year 8 at 8 a.m. is going to be your 9 at 6:55 p.m. when you're ready to get off shift and stuff. So it's an arbitrary and imperfect system. Eat, sleep, and console is a little bit more focused on the function of the baby. Are they eating okay? Are they sleeping okay? Can I console them? I don't care if I care, but for the purpose of making treatment decisions, if their tone is a little bit up, if they have a 99.1 temperature, those are things for me to think about. But if they're eat, sleeping, and consoling, I'm not going to transfer them and give them medication in that context. So what we've kind of found at our institution is that the number of babies that have needed pharmacologic intervention since going to eat, sleep, and console has dramatically dropped off, from babies being in the NICU for 6 weeks on daily scheduled methadone, some of them being sent to me for me to do an outpatient methadone wean, which is a gut tester big time, to now babies maybe getting a PRN dose or 2 maybe, but really not a lot of pharmacologic intervention in the hospital. Okay, you start early, within the first few hours of birth. The assessment should include the entire period of time since your last assessment. So the classic I had was like, the nurse called and said the baby looks terrible, and then I get there and the baby's asleep. It's like, well, crap, the baby can't be sick and well at the same time, right? So let's think about this whole block of time. Overall, how's the baby been doing over that time when we're making these kinds of decisions? I'm not going to go in depth into eat, sleep, and console because it sounds like y'all are already doing this. Making sure the team huddle includes all those same kind of folks that we talked about before. Make sure that everyone is involved, including lactation, okay? And then if you've maximized non-pharmacologic care and they still aren't doing well, then do some medicine. And that can include morphine, methadone, or buprenorphine. Commercially available buprenorphine products for babies have alcohol in them. So the only institutions I've ever known that have used buprenorphine in baby care have a compounding pharmacy internally that can make their own without alcohol. So our docs use PRN, morphine, or methadone mostly, our NICU folks. Okay. Now for discharge planning, we want to make sure that outpatient pediatrics is arranged. I want that baby to be seen within 1 to 2 days of discharge because they could have some delayed withdrawal, but mostly because I want to get another set of eyes and hands in on this baby as soon as possible so that we have that structure of a medical home outpatient. And then getting them, I refer every baby to early intervention that has had intrauterine drug exposure because they are all at increased risk of developmental delays, and it's another set of hands on deck in the care of this family unit, another set of eyes on the home situation and the like. So I think from my perspective, it's a universal. So just a couple kind of pearls and pitfalls from my perspective on the hospital side of things. Don't do a circumcision until you're going to send the baby home, because if you do it on day 2, they're going to be more fussy. It's going to confound your assessment of that baby. Just wait until the day they're going home, do their circumcision, send them out the door after you know that withdrawal's peaked and troughed and starting to come down. Don't let circumcision be a thing that makes it harder for you to make decisions. It's easy enough to wait 1 more day or 2 more days. Remembering that most drug tests that are readily available do not detect buprenorphine, fentanyl, methadone. So sometimes if needed, we'll send those out for like an expanded opiates so that we can pick those things up. Trauma, particularly sexual trauma in this population is almost universal. So as a male caregiver that rounds at 5:30 in the morning, I often think about this. Like, I'm coming in a dark room, they're tethered in bed by an IV, their genitals hurt, they smell blood, and now I'm gonna surprise them and wake them up. Just be aware of how that goes over for them, and the way you interact with those patients. Stimulant intoxication can look an awful lot like preeclampsia or eclampsia. They will have elevated blood pressures, and they can have seizure. Theoretically, labetalol can cause some blood pressure issues in a cocaine-using person. So hydralazine would be the drug of choice if you were going to treat an elevated blood pressure in a person with known cocaine use, which is probably not your institutional first line for this. Cannabinoid-induced hyperemesis can look like hyperemesis gravidarum, so make sure that you're asking questions about cannabis use in that population. And then one of the things that we did that was very important to the care of patients at our place was to find some core nurses that work there that had some extra interest that in this group, taking care of this group of people, and then we would preferentially make that assignment to those nurses. It helped with the standardization of care immensely. And I think it helped the nurses feel better about it, because there's some folks, for whatever reason, and I don't care what the reason is, that don't like taking care of people with substance use disorder. Don't make that nurse do something that they don't love, that they're not comfortable with, if there's an alternative. And I think it helps a lot on the mom side of things too. If they're having somebody that's using softer language and a little more compassionate touch, the experience is going to be better for them. And what we found is that a lot of the nurses that weren't self-identified core nurses have decided that they were interested in this as they've seen it kind of play out. Certainly language has gotten a lot better at our institution. We're not taking care of cocaine babies and methadone babies anymore. We've gotten a lot better about how that's been done too since we've done this core nursing thing. So just remembering addiction is not a moral failing. It's not a lack of willpower. It's not that they're not brave enough to get better. It's a medical condition that's due to aberrant neurochemistry that we can see on functional brain scanning. So if we